Let's suppose that you are in your surgical emergency when this handsome soldier walks in. But he complains of some abdominal discomfort for some time. When you take his history and when you dissect the complaint of abdominal discomfort, you realize that his pain was originating from paraumbilical region, and from there it was radiating to right iliac fossa. When you take the history further, he explains that he has also been having some episodes of vomiting, and that he also has anorexia. It means he cannot eat anything, and whatever he eats usually comes out. He also explains that he has some nausea. Now, there are some symptoms that can vary. I mean, they may or they may not be present. For example, some patients can complain of pain on coughing or laughing. Now, after you have seen these symptoms of the patient, you may have some idea in your mind about what may be going on in this patient, but you're not sure. So, what's the next step? The next obvious step here is to examine the patient. For examination, a first step, you have to see the general physical appearance of that patient. Now, patient may or may not look sick. Usually they do when an ongoing inflammation or infection is in the body, but it's not necessary. You start by taking the pulse. When you take the pulse, you realize that the pulse is increased. Later on, when you take on your thermometer and measure the temperature in his axilla, what do you see? You see that the average temperature is about 37.2 degrees centigrade to 37.7 degrees centigrade. Now, this is a textbook range of the temperatures that are given in the infection that we're talking about here. Further, when you go to the extent of examining the abdomen, there are certain very specific signs that you're going to see here. The first sign will be visible on inspection. On a very normal inspection, when you haven't even touched the patient, you can see something, and that something is going to be related to the lungs. You will see respiratory restriction. Now, why does respiratory restriction happen? Whenever an ongoing infection is there in the abdomen, it will restrict the normal movement of the lungs, and that is why you're going to see this restriction. That is something you will observe on just a look at the patient. After that, when you go to the extent of touching the patient, there is something very obvious that is going to happen, and that is the guarding of the muscles. What is the guarding? Guarding is a phenomena in which the muscles of the abdomen become taut and their tone increases whenever you touch them. It is also an indication of an ongoing infection. The third phenomena that we're going to see here will be very obvious again. It's the tenderness in the right iliac fossa. This tenderness is elicited on superficial palpation. However, if you will go for deep palpation, as the person here is doing, then you will see that the moment you take off your hand, the patient will experience pain again. Now listen to it carefully. The moment you take off your hand, the patient experiences pain. This pain and this tenderness is known as rebound tenderness. So it is very important that you're looking at the patient's face and not at the place you're palpating to see the rebound tenderness. This is the fourth thing that you're going to see. The fifth thing that is not very essential in itself, but it can be elicited, is the pain on palpation of the right iliac fossa. Similarly, you will have to look at the face of the patient to see the expression of pain. As we've already seen here, there are 5 symptoms you're going to see: respiratory restriction, guarding, tenderness, rebound tenderness, and palpation. Now, when you're done with these general symptoms that indicate that there is an infection, you have narrowed down your diagnosis, but still, you need to see some very, very, very specific signs that will indicate towards one diagnosis. To see those signs, you will have to make a questionnaire. You will have to ask the patient if those signs are present or not. They're not necessarily present, but their presence indicates that the infection is indeed the one you're thinking about. In this case, infection is appendicitis that we're narrowing towards, and there are several very specific signs of appendicitis. For example, if you look here in this diagram, of course, the physician has asked the patient to locate where exactly she can feel the pain, and she's locating towards a point. Now, this point is a very important point. Usually, in most of the patients, this point is located between the umbilicus and anterior superior iliac spine. This is umbilicus, and this is anterior superior iliac spine. Then there's a line that lies between them, and there is a point that is at a distance of about 1/3 from the anterior superior iliac spine and 2/3 of the line from the umbilicus. This point is known as McBurney's point. Now, McBurney's point is a point where the pain is most pronounced in a lot of patients. So this sign here is called the pointing sign. Let's name it. Now, it is very important and a very true indicator of an appendicitis. The second sign, in fact, here will be the Rovsing sign. What is a Rovsing sign? This sign indicates that if you will palpate on the left iliac fossa, the patient will experience pain in the right iliac fossa. This sign is again a very good indicator of the infection in our discussion. Now, there are 3 more specific signs, and these signs depend more upon the position of the appendix, and they're a better indicator of the position of the appendix instead of the infection. I mean, we all know that there already is an infection, but these signs will tell about the position where the infection is happening. For example, this one here is called a psoas sign. Now, if you can see closely, you can see the psoas muscle here. This is the muscle, and this is your acute level appendix. Now, the appendix is lying on the psoas muscle, so when the appendix will be inflamed, it will cause contracture of the psoas muscle. And since the psoas muscle is a flexor, it will flex the patient's leg. Just like this, somewhat like this. So if you will see a very, very, very diagnostic sign of a patient of appendicitis will be that the patient will be lying on his right side with his right leg flexed because of the contracture of the psoas muscle. But if this sign is not very pronounced, you can check that if the psoas muscle is really contracted by extending the leg, as this patient here is extending the leg. It's usually the passive extension of the leg that is brought about by the surgeon. So this is the 3rd sign here that we talked about, and this was the psoas sign. Similarly, there is another muscle that is attached to the hip bone, and that is the obturator muscle. The obturator muscle also gives a sign. This is the expression of pain, or the just a patient experiences pain when you flex the leg and then you move the hip joint inwards. When you do that, the patient experiences pain, and it again elicits that the appendix and the infection lies somewhat close to the obturator muscle. And this is also a very telltale sign of the appendicitis. Now, when we're done with the major signs of the appendicitis, the other thing that is very, very, very important is the position of the appendix. Now, in these diagrams, these are not 5 appendices in one person. Instead, these are the 5 major positions where the appendix is found most commonly. If you will see this one here, This position is called instead it's post-ileal. I always make this mistake. Post-ileal position. Because it is behind the ileum. That's what confused me. Now this position here is called the pre-ileal position. Because this is your ileum here. And it's lying in front of it. So it is pre-ileal position. This one here is the pelvic position. This here is the subcecal position. Because it's lying under the cecum. Now the position that is behind the cecum is very important, and it is known as retrocecal position. Now in most patients, the appendix is retrocecal, and the frequency is about 74% of patients' appendix is retrocecal. Very important for you if you're ever going to pursue surgery and if you're ever going to cut it open to locate where the appendix is. Similarly, about 21% of them, in about 21% of the patients, the appendix is in the pelvic position. Now, why are these positions so important? They are because different positions are going to elicit different symptoms and signs. For example, if you see the retrocecal position, as you can see in this diagram, where this is the cecum, here, this is the anterior abdominal wall consisting of the skin, the fascia, the muscle, and this is your appendix that is lying on the psoas muscle. In this diagram, it is very clear that the rigidity and the tenderness will be absent because of the gas in the cecum that prevents the peritoneum from reaching the inflamed structure. Because of that, you can easily write that the first sign in it will be absence of the anterior abdominal wall tenderness. Similarly, the second sign that you're going to see here will be the psoas sign. It's very obvious because the appendix is almost lying on the psoas muscle. The third sign that you're going to see here will be that the deep tenderness will be, it's not found in the anterior abdominal wall, but it will be found in the lines. So these three signs were very different from common presentation. This is important to know that this will happen if the appendix is retrocecal. Now, let's suppose the appendix is in a different position, as it is in a pelvic position here. It's almost directing towards pelvis. The signs that you're going to see here will be different. Symptoms in fact. As you can see that the appendix is lying very close to the bladder, it will cause increased frequency of micturition. Similarly, as the appendix is also close to the rectum, it's not that close in this diagram, but it actually is, there will be increased diarrhea. As it is very evident here in the diagram, that's a ridiculous diagram, but anyway, that psoas muscle and the obturator muscle are also very close to the appendix, so you're going to see both of these signs. So this is the first sign, this is the second, the third sign is the psoas sign, and the fourth sign is the obturator sign. The fifth sign that you're going to see will be exhibited when you will do per-rectal examination, and per rectal examination you will find that there is a tenderness when you touch the retrovesical pouch, or the pouch that we call the pouch of Douglas. So pouch of Douglas is tender. And this was the condition that we were discussing in case of a pelvic position of the appendix. The third position that is also presents differently is the post-ileal. In this case, the appendix is lying behind the ileum, and similarly, it will not have any anterior abdominal wall tenderness, because the same reason that if the ileum is filled with air, it will prevent the attachment of the infected part from the peritoneum, and that is going to prevent the tenderness. Now, when we've discussed this position, there are we were discussing in the context of different presentation of symptoms. There's another criteria that makes people present with different symptoms, and that is the age. When I talk about the age here, you will see that in infants, usually appendicitis is not common. I mean, it's very, very rare in infants that are under 36 months or 3 years. However, the incidence of perforation or post-operative death is very high, and that is because the patients cannot give a history. Similarly, I mean, it's not similar, but you can say that it's the cause of death. In fact, the thing that you're going to see in infants the most will be diffuse peritonitis, because you cannot treat them on time, so the infection spreads way more than in adults, and it causes diffuse peritonitis. Now, if you go towards the age group of children, then you see that two symptoms, in fact, are very prominent in them. Number one is the vomiting. Let's make them vomit. Number two, diarrhea. Similarly, not similarly, in at least, I mean, in fact, in absolute contrast, in elderly, the thing you're gonna see will be gangrene and perforation because of the already weakened appendicular walls. Now, these were the three criteria that divided everything on the basis of age. Two more criteria that we can see here are the obesity and pregnancy, the fat and the fetus. Now, in an obese person, it is extremely difficult to diagnose appendicitis because of the diminished local signs. So, let's write it this way: diminished signs. Scenario becomes totally different when we're talking about a pregnant lady. I mean, in a pregnant woman, they develop appendicitis with the same frequency as the non-pregnant woman, but this is the most common surgical disease of the abdomen that happens during pregnancy. So they usually present with right lower quadrant pain and tenderness. And after that, it usually happens because of the uterus, the size of the uterus, because this uterus pushes the appendix upwards, as you can see here. In this case, the complication that usually happens is an early perforation, so you have to stop that. And to stop the early perforation, and why does the early perforation happens, by the way? It happens because the appendix is less available. Sorry, the mesoappendix is less available to the appendix. The peritoneum, and for that reason you have to do early operation to save it. Early appendectomy. But in this procedure, you're not gonna give the usual surgical scar. The usual surgical scar. No, the usual surgical incision. I mess up at the times. It's okay. Instead, you're going to give another incision, which is known as, very important to remember, the Rutherford Morris incision. This incision is given in pregnant women specifically when they present with appendicitis. That was all regarding the signs, symptoms, and blah 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 of the appendicitis. Hope you understood it. See you soon again.